Okay, hey everybody, welcome. I'm going to start here in just a couple of minutes to give our stragglers time to jump on. And hope you're doing well. I need to upload this slide presentation. I was having a difficult time doing it. You can thank technology for that. In the meantime, as we wait another minute or so, why don't you go ahead and go to the file sharing on your sidebar and let me know if you can download the file. This is called Sample Client PDF. And also, please go ahead and check the chat because I popped in a link in there for something for you to download. That's the new survey PDF. So go ahead and do that. And I think I've got one other thing here. We're going to roll this out here. Okay, I got one other thing for you guys to download if you haven't already. It's also there in the chat box. Can everybody hear me? Please raise your hand if you can hear me. Please raise your hand if you cannot hear me. I cannot download the file. Can you send notes in advance PDF? So these are just links. These are URL. Okay, great. You can hear me. Okay, excellent. Okay, so click the link. There's two things there to download. There's the client survey PDF and then the 7 mechanisms of clinical investigation PDF. If you don't have that ebook already, we were sending those out a couple of weeks ago, but we got them here now. All right, so I'm having some technical difficulties with the file upload for the slides. So what I'm going to do instead is a screen share to get this party started. And bear with me a second as I close all my stuff. Okay. Summer Sessions Week 1. We're going to be sending out these slides after the presentation. I've got 83 slides to go through today, so there's going to be quite a lot of material to cover. And we don't really have much time to waste. I'm going to jump right into this presentation now. It's great to see everybody here. And if you have any questions, we're going to do a little bit of we're going to do a Q&A at the end of the presentation. And so yeah, you can feel free to drop questions in the chat and I will get to them later. Let me do a screen share and we're going to get this party started. Give me 1 second, I'll be right back. One more technical thing. Okay, I think we're about ready here. Well, the slides, I was working on them up until 5 minutes ago, so I wasn't able to send out a link yet, but we will have those ready for you. Okay, so I'm going to do this just in case. I'm going to have to export this to a PDF first. I was having a difficult time. It wouldn't upload my file for some reason. Okay. Okay, let me go and do a screen share now. Hopefully that did it. Whiteboard off. Okay, so let's get going here. 7 mechanisms in chronic illness. This is what we're going to be talking about today. And this is really, really cool stuff. I'm really, really excited to present this information to you. And, you know, the 7 mechanisms of clinical investigation are, in my opinion, something that we cannot miss. We have to be looking for these in every one of our clients because of the fact that we're dealing with complex illness, and the environment that we live in is no less toxic. It's not going to get any less toxic anytime soon. Genetic expressions are going to become more and more complicated and involved as we go deeper into the realms of environmental influences on illness. That includes the stealth infections of Lyme disease and their co-infections. That includes environmental toxins that are bombarding everybody in civilization. That includes a convergence of how gene expression is being affected by all of these different vectors. So we have to be really looking at these things. And now I have to credit my good friend and colleague Sean Bean for helping to create many of these mechanisms. And many of these things you are probably looking at in your practice already. But this helps to, in my opinion, it helps to really kind of contextualize the whole process. And actually now what I'm going to share with you today I want to kind of break down sort of the clinical process of how to actually pull apart these 7 mechanisms from your intake when you're working with patients or clients. And ideally, you start to pull these 7 mechanisms out in your intake initially before the first consultation. And I find that before and during your first consultation. And so there's basically 3 different mechanisms that we can use, 3 different methods that we can use to do that. So number 1, we can use an intake form. So if you go into the chat and you click the new client survey, I believe is the PDF, that you're free to use that. I created that. This is what we use and I use in my practice with my clients. And you're free to use that. You're free to integrate that into your own practice. Download it, get familiar with that. We're going to break down a lot of those sections in this presentation today. So the intake form you send to the client, this is what I recommend doing, sending to the client before the first call and really getting into it with having them fill that out so it gives you proper assessment. Now, what you're going to find, what we found, is that the intake method is effective for certain things, but there's certain things that they just need to tell you. And this is why we like to have the client write out their actual story. And there's something about storytelling or story writing that just enables to take the blinders off, that enables the client to become more vulnerable, to just present more information that you wouldn't have necessarily assessed. They may be more comfortable in disclosing certain things to you when they write out their story. Especially, this is really something that you have to dance around very carefully when dealing with trauma. If a client has been traumatized, which so many people in some way have, this is something that you have to just wait for them to carefully lay this out. And they may not be ready to, but the intake form is not, in my opinion, is not the best way of assessing trauma. That's better assessed through just having them write it out or maybe talking about it with you and the client. So in the consult. So the third part is when you're actually working with the client during the initial consultations, not only the initial consults, I should actually say throughout the entire process of working with the client, of actually taking extensive notes that will help to pull apart these 7 mechanisms. So this is an example on the intake form of how to create an intake form. Again, this is all for those of you that are just joining on. You can download this in the chat. I put up the links. Please do that. Integrate this into your practice. We're going to break it down further today. So this is just an example of how you can pull, and most of you probably already are doing some kind of intake already with the client. So you can integrate these 7 mechanisms with the form we sent you. This is the second method that I was talking about, the client writing their own story. This is just an example. So here's the 7 mechanisms that you see on the right. And what I do is I actually go over their story with a highlighter. And I pick it apart and I say, okay, black mold, there's your environmental trigger, number 1. That's your 7 mechanism, number 1. Okay, here, bitten by a tick, high probability for pathogenic vector, Lyme, etc. Okay, trauma early life, barely made it when I was born, etc. Violence, there's trauma, boom. That's number 3. Number 4, Structural, hypermobility, subluxation of the joints. Bang, you've got that. Number 5, ciprofloxacin. So it looks like they've been floxed. That's a medical iatrogenic variable. That's our 5th of the 7 mechanisms. Bang. Number 6, there's a history of autoimmune disease in the family. That's a possible genetic association. That's our number 6. And boom, number 7, sulfur sensitivities plague me. Bam. So you're picking it apart using your highlighter. This is their own. This is the client writing you the story. You're picking it all apart, and you're basically looking to find all of these things. Now, again, I want to really, really point out to you the significance of these 7 variables. We have to be looking at them. I want to actually go back to the beginning and just say, if you're not looking for the environmental trigger, you can save the client tens of thousands, hundreds of thousands of dollars by detecting mold on an intake form. I'm serious. And there's cases that I can give you examples of clients that had gone to the Cleveland Clinic or had gone to the most prestigious medical institutes in the country, in the world, spent tens of thousands of dollars trying to find out what's wrong with them, and everybody misses the one thing. And I'm telling you that if you can isolate the one thing, or the several, there's always more than one thing, but if you can find the things that are missing from the investigative process. Very few clinicians today are doing in-depth clinical investigative work. Very few clinicians today are spending the time to go over with a fine-tooth comb these mechanisms. They miss it. Instead, what we have are doctors and other so-called integrative, conventional, and or functional medicine providers basically treating numbers on tests. And that approach fails because you've always got to start with the storytelling, first of all. So that's what we're trying to do with these 7 mechanisms. We're trying to really pick it apart, and we're trying to really look at the causative factors that are occurring and trying to get down to the bottom line immediately, as quick as we can. The sooner you can pick out these 7 mechanisms from the earliest point of contact with the client, the better chance you'll have to get optimal results with the client, or to even refer them to the right clinician or practitioner if it's something that you're not an expert with, such as trauma, for example. So again, we want to get this from the beginning, or as close to the beginning as we can, because of how critical these variables are. And at the same time, we want to be able to develop a system to be able to track the symptoms and or the conditions that have arisen as a result of these 7 mechanisms, right? Does that make sense? So again, to reiterate that point, we want to be able to track the client's progress over time. If you're working in chronic illness with patients or clients with chronic illness, they're not going to get better tomorrow. It's going to take a while. You're going to need to develop a 6-12-month plan, to be able to take them from point A to point B, or help them to get from point A to point B. And so you need to develop these sort of a tracking method. And I'll give you an example as we look at the end of the call. So this is the third part is taking notes during the initial intake. So these are my notes. So this is during the first consult, I'm typing. And the client forgot to tell me in the initial intake or in the story that they lived in a mold-infested apartment for 3 months that eventually led to a biohazard sign and the total removal of the building. So, the client forgot to tell me that. Well, thank God I was able to pull that information out from the initial consult. Had I not done that, I may have missed it completely. Oh, look, they forgot to tell me on the intake form and in their story that they had 2 weeks of Levaquin, so they were probably floxed. And they forgot to tell me that they have symptoms relating to EDS and hypermobility, which further damages the connective tissue, furthering the assault that Levaquin could be doing on their ECM. So again, these things they're really significant when you start to pull the pieces together. And the thing that you'll start to find out is the associations and relationships between these 7 mechanisms of clinical investigation. So just as I mentioned, assault to the connective tissue because of mold or a genetic predisposition to EDS is going to mean that an iatrogenic drug like Levaquin, for example, in this case, could potentially be catastrophic. And so to be able to assemble the timeline in an intake process is very, very critical to arriving at a hypothesis about what has occurred and why is this person so sick. This is the level of thinking, this is the level of detail that you need to be going through. This is your job to do this. I'll just point that out. This is your job to really, really pull this information out, lay it all out on the table, and get down to business as quickly as you can. Okay, so what I want to do now, and again, if you have any particular questions, you can pop them up. Some people were asking just a moment ago, they can't see the sample client PDF. Just download the links that are in the chat. Just scroll down to the bottom. Okay, so what I want to do now is to actually go through some of these indicators on the intake form. So using an intake form can be very, very valuable to be able to have the client just create a checklist, and that's basically what I've sent you, the new client survey. It's a checklist, and you have them fill it out. So with respect to mold and mycotoxins, this is a pervasive problem, and I am always looking for mold. I'm always looking for it because there's a high probability that somebody has been exposed to mold in some way, and if they have chronic illness of some kind, there's a greater probability that mold toxicity or chronic inflammatory response to the mold is more possible. So I'm looking for it. And by looking, it's really important when you're assessing mold on an intake to get the environmental data. Has there been flooding in the basement? Has there been any degree of water damage in the house? Can you smell mold in the house? Do you have an HVAC system that's been in the basement which is flooded? How many times have I found mold just by asking that question? So the HVAC system circulating air throughout the rest of the house from a basement or from an air intake from the part of the house that has mold in it. The HVAC system, heating, ventilation, and cooling, notorious for harboring mold spores. And if it's not been cleaned out, you've got to find out. So again, you've got to be an environmental detective when it comes down to mold. So really, really looking for it in the house. And I found that these questions are really, really critical because they will lead you to developing the types of testing that can help to evaluate which molds may be present, and possibly is the person excreting mycotoxins? Are they having an inflammatory response to the mold? So the intake can become the bridge towards a deeper investigation in this particular area, in a particular area. So we also want to be paying attention to the biological effects that mold could be having. So some of the neurological effects that mold can induce. Remember that mold is a biotoxin, and that the research that Shoemaker did several years ago found caudate nuclei atrophy in the brain. So, and you can read that paper as well as Dr. Bredesen's paper. Inhalational Alzheimer's is his paper. So we know that there is a direct effect of literally brain damage that mold can have. So we're looking for clues that may correlate with the environmental component, loss of cognition, confusion. Neuropathies are very common, burning or tingling sensation. So it's important to point out that a lot of the symptoms that you'll be getting do not only apply to mold. There can certainly be overlap with other conditions like Lyme. So, but we're looking to assess probability. That's all we can do, right? What's the probability that a person's neuropathies are being created by a biotoxin or mold exposure? So if we see the environmental component on the intake, if we see, the symptoms presenting, then there's a higher probability that that's happening. So capillary hypoperfusion is a term that Shoemaker coined to basically indicate that there's inflammation occurring in the microvasculature leading to poor oxygen delivery to the peripheral tissues. So there's an underlying physiological meaning and basis for these intake questions. Acute respiratory, obviously we know that mold can create sinusitis or fungal rhinitis or MARCoNS to persist. So we're looking to assess those as well. There can be endocrine and cardiometabolic symptoms associated with mold. Remember that vascular endothelial growth factor can be low or high in mold. That's a biomarker that's often tested. And VEGF is a critical regulator of angiogenesis and of oxygen delivery to peripheral tissues during hypoxic states. So it leads you to start in your own clinical process, in your clinical thought process, thinking about how mold could be creating cardiometabolic complications and symptoms. Now, it's not been proven, so loss of sex drive or vaginal dryness in females, it's not been proven that mold inhibits estrogen or alters estrogen metabolism. However, there's clinical evidence that that's occurring. There hasn't been a study that I know of, but we know from aflatoxin research that aflatoxins can inhibit CYP3A4, which is the enzyme that produces the estriol, as well as the 16-hydroxyestrogen. Estriol promotes like vaginal lubrication. So there's clinical evidence that there's hormonal disruption that mold can induce. So we're looking to pull that from intake. Unquenchable thirst, constantly feeling like you're thirsty. That's a depletion in ADH, antidiuretic hormone. Again, that's an endocrine disruption. So because of the effect that mold can have on the brain, ACTH, for example, could be jacked up, dysregulating the HPA axis. So common symptoms could include insomnia. And then we have other things like loss of motor tone and muscle function and things like this. So again, there is overlap. So it's not just because somebody answers yes to some of these doesn't definitively mean you've got to just look at the overall evidence. In terms of the ECM connective tissue stuff, it's really been an interesting assessment that many people that are hypermobile, that have joint hypermobility, are either predisposed to having mold-related illness, or the mold causes hypermobility. And we'll talk a little bit about that later. So that's why that's here in this section, because metalloproteinases, for example, that get activated by mold infiltration leads to a breakdown of the collagen in the connective tissue. So, and then here's some familial associations. So a lot of the HLA variants on chromosome 6 that predispose to chronic inflammatory response syndrome, they're very similar in that the autoimmune disease susceptibility is also on chromosome 6 in the HLA region. So that's why I popped it in there, because we do see common associations between autoimmunity and mold illness. Okay, so now what can you do with this? So follow-up testing. So for environmental testing, I still recommend the Hermey-Hertz-Me2 scoring. So from Mycometrics or Envirobiomics, and I like the cloth detection method. So the person actually samples from suspicious areas of the house where they believe mold to occur. So Envirobiomics is the newer company. Mycometrics has been doing it a little bit longer, but these are both PCR DNA-based tests. And the Hertz-Me2 score, which I'm going to show you how to do that in a moment, is extremely valuable for identifying. The higher the Hertz-Me2 score is, the bigger the problem it is potentially. Then people have used the mold plates. I haven't gotten into this as much, although I've got a lot of people and colleagues telling me that it's been very useful for them. And you can use createyourhealthyhome.com is the website that I've referring people to for mold plates. But I do prefer the Hermey-Hertz-Me still as the number one. So some follow-up biological testing for mold. So the Great Plains urinary organic acids test, in my opinion, outperforms the Great Plains, the real-time labs. I like the Great Plains better because so real-time uses a method of assay called ELISA, versus Great Plains, they're using mass spec. mass spec is far more sensitive than ELISA method is. For that's the main reason. So I like to use the Great Plains mycotoxins for that. But guess what? You can also pull mold probability by looking at the organic acids test, the Great Plains O test. I'm going to show you a slide in a minute. And then in terms of the blood markers, these are non-specific for mold, but they usually are involved in SIRS. And these are the top 5 that I've kind of whittled it down to that I found to be the most valuable in looking for chronic inflammatory response illness. C4A, which is a part of the complement innate immune response. TGF beta 1, which is our, in pro and anti-inflammatory cytokine and growth factor. VEGF, metalloproteinase 9, and antidiuretic hormone. So this is the ERMI-HERTSMI test. This is an actual result from a client with lots of mold going on. So the ERMI is what you're seeing here on the left. And basically what you need to know is that there's all kinds of different molds that can show up. The cladosporium that I didn't highlight, the cladosporium that you see at 5003, Epicochium nigrum, these can be from plants. Certain plants can give off mold and can cause problems. So actually, I had a client that had to get rid of all of her plants because she realized that was one of the main sources of her problems. So you just have to, again, you got to just pick these things apart. So the ERMI test, basically, I've highlighted the 4 of the 5 major molds that you want to look at to create the HERTSMI-2 score. So the HERTSMI-2 score is something that was created, I believe it was Dr. Shoemaker that created it. The HERTSMI-2 score helps to basically put a number on the degree of toxicity that the mold is inducing, that mold is having in the house. If the HERTSMI-2 score is greater than 15 and the person has an inflammatory response to mold, it's imperative that they remediate and leave the home. Leave the home or suffer the consequences. Move, remediate, or suffer the consequences. That's basically what I tell clients. So as we see here, and it's very simple. You can save your client $100 by doing this yourself. So, because the lab will do the HERTSMI-2 score for you, but this will take you 30 seconds to do on your own. So the Aspergillus species, so it has 8683 is the number. So on the HERTSMI-2 score, we see that Aspergillus, you plug it in there, and you assign it 10 points. As you look to the reference, 10 points are assigned with an Aspergillus penicillides greater than 500. So this is really high, actually. The Aspergillus versicolor, 274. So you look for that on the chart. That's coming here on the second category. You assign 6 points to that there. For the Chaetomium is 44. So you look for that. Chaetomium is, for 44, is right in here. So that's 6 points for that. Stachybotrys, 24. So you would assign 4 points for that. And Wallemia is 1603. You would assign 6 points for that. So that's a HERTSMI-2 score of 32. Remember, the cutoff is 15. She is symptomatic for mold. She does follow a lot of the same symptom scoring. So this test was extremely valuable to just figure this out. And she was using this over time, post-remediation, to find out if the house was safe. And this is something that you've got to really do. The most important thing you got to do with somebody that's exposed to mold is to find it and to do the proper renovation or remediation or move. The OAT tests, Great Plains Organic Acid Test, potentially very, very valuable. So Section 1 of the GPL OAT test can reveal several markers of mold, 4. So markers number 1 and 2, so the citramalic and then the 5-hydroxymethyl-2-furoic, these are major mold indicators. And Great Plains did an evaluation that compared mycotoxins that were elevated with these markers. Number 3, clinical evidence suggests that oxoglutaric, the 3-oxoglutaric, is associated with black mold or Stachybotrys. We have clinical evidence of that. And then number 4, according to Great Plains, furan 2,5-dicarboxylic, this is also a primary mold indicator. So if you see these showing up, you're potentially looking at mold. That should really alert you to ask more questions during the intake or whenever you talk to the client next. And then according to Great Plains' evaluation, markers 22 and 24 on the O-test, the lactic and the succinate, are also associated with mold. These are secondary mold markers because these can be certainly high for many other reasons. So as we see here, the lactic is 250. This is off the chart, and this person was exposed to mold. 24 can be associated with vitamin B2 deficiency. That can also be associated with a low thyroid condition. You have to kind of pull apart those as well to see if 22 and 24 correlate with other things. Here's their mycotoxins test. So if you haven't run this, it's very valuable. I found this to be very, 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 very valuable in certain instances where it was really difficult to detect. So ochratoxin A will detect Aspergillus or Penicillium. Aflatoxin M1 is basically Aspergillus from foods showing up. And Varicarin A, this is Stachybotrys, Fusarium, and Mycothecium. And this one is Fusarium. So Great Plains mycotoxins test. Overall, I almost use the organic acids test with almost every client because there's so much data. And when we work in our one-on-one mentorship program, this is one of the primary tests that we actually run through with each of our clinicians. We teach in depth how to look for pattern recognition on the urinary organic acids test. And the test from Great Plains over Genova is what we really are into. So just to give you, I'm not going to cover extensive mold protocols because there just isn't time to do that. But I want to give you some updates on what some of the recent therapeutic wins are that I've been using and finding to be valuable. So I've been using nebulizing biocidin. So biocidin obviously is the one of the useful herbs for treating microbial imbalances, as we all know, and it's usually taken internally. However, there's evidence now that nebulizing it, putting it in an actual nebulizer, so this is a nebulizer tube that you hook up to the actual nebulizer device, which is this, and it's actually a very easy process. You could use 1 to 2 capsules, or you can use the liquid drops. It's all liquid, so it doesn't matter, but it basically turns the herbs and the oils into vapor so that you're inhaling them. This is showing to be very useful for mold-related sinus infections. I'm kind of at the place that I agree with Dr. Nathan's analysis, that at least the last time I heard, that Marcons, you'll never get rid of it, or sometimes you never get rid of it, so don't even worry about it. But if the person is really symptomatic, sinus-wise, then they got to try something, right? And so the nebulizing biocidin has been very valuable, I found, for alleviating some of the sinus-related symptoms. The other thing that I found to be very valuable is the Nasobiotech probiotic, which contains Lactobacillus sakei. So this is an actual probiotic powder that you insert into your nasal cavity. And there's been instances where this has been really effective. I published an article on my website last year that talked about Lactobacillus sakei. There was actually a lot of people that were doing this using kimchi, but it turns out you can now, this company came around and basically started selling just the sakei probiotic. So I've actually played with it, and I found it to be quite useful. And if it works, it usually works pretty quickly. It may also alleviate histamine-related reactions, especially seasonal allergy symptoms as well when taken nasally. The use of multi-binding agents. So for me, it's not about using just one, but it's about using multiple binding agents. So I like the Biobotanical GI Detox plus liquid bentonite together, that combination seems to work really well for me and the clients that I'm working with. And always optimizing hydration and electrolytes because of the effect of mold on the hydration system and on the effect that it's having on antidiuretic hormone, or potentially having on that. Electrolyte imbalances in electrolyte and hydration is so common, and it's one of the fundamentals of health that are being overlooked. So when you're dealing with a mold client, really hit the hydration. The cell can't function if the charge is off. Just remember that. So the electrolytes, I like, that people are going to ask me, I like the Seeking Health electrolytes. I do. I think it's well formulated. I also like the Health Equations electrolytes that Dr. Lynn August has formulated, because it has phosphate and sulfate in it, which is really, really rare for electrolytes. So I like either of those two. Toxic metals and chemicals. We're not going to spend a lot of time on this section, but this is something that you also want to pull through your intake as well. Look for some very common things. Again, being an environmental detective, obviously the amalgam issue is real, and if they've had a lot of amalgams in their mouth, that's a mercury issue. But also look for other sources as well, like copper pipes. Copper or iron pipes. A lot of the older houses built in the 100 years old or older have corroding pipes, and if they don't have water filtration in the house, it's going to get into this. It's going to get into the water. Especially worse if they have a water softener system, as I put, because the water softener system will make the water more acidic, therefore causing minerals to be pulled out of the pipes that more readily. So find out if there's a high exposure to toxic metals in the hometown. Usually if you go on to there's a good website, you can write this down, scorecard.org. Scorecard.org. It needs to be updated, but if you plug in a zip code in the United States, it will basically give you a breakdown of the major polluters in your municipality. I found this to be really useful when trying to find out the toxicity component. Especially like a lot of people living in previous industrial cities, like in Detroit or in New Jersey, which is just so toxic in the water. So, there's so much going on in the environment that we need to really be more aware of. I don't personally know or believe that the water tests that you run through these basic companies are very valid. I've not found them to be, and I found inconsistencies what the actual municipality is testing. You can also go to the city or municipality that the client is living in. If you know the city, and just Google it and see if the city council has released the water table data. I found that to be really relevant in many cases. There's so many toxic municipalities, it's really incredible in how this is being missed. So you can find this information by sussing it out through the initial intake. So we're just looking for toxic metal exposure. A lot of these neurological symptoms, again, they'll overlap with other conditions, but we want to just see if there's a correlation to any of the environmental factors. Same thing with the endocrine, gastrointestinal, and cardiovascular section. There is a lot of overlap, so we don't always know, but we're just looking to evaluate the probabilities. So you can play with this with your intake. Again, feel free to integrate that client PDF. I'm going to say it again because it looks like there's a bunch of new people that have jumped on here. That in the chat, I put in the you can go ahead and download the PDF, the client survey, and you can integrate this into your practice. So signs and symptoms of chemical exposure. So there's that link, scorecard.org. Go ahead and plug that in. And this is the other link that I have the client just go to directly. And that's hyperlinked in the PDF, is the environmentalworkinggroup.org, EWG, the interactive map for hexavalent chromium in the United States. I found that to be highly relevant, very valuable. Hexavalent chromium is a carcinogen. This is a big problem in all over the country, really. And you need to be evaluating this, because if there's the presence of that, it could certainly be creating problems, and it's leading you to do further investigation. It could even lead to, a lot of these problems that we're dealing with the clients. These are environmental problems. These are things that have to be resolved with remediating the house with mold, cleaning, getting the proper water filtration, getting the proper air filters, getting dehumidifiers going. These are environmental problems. A lot of the problems you're dealing with, you may not even know it yet, these are environmental problems in the house. Okay, so moving right along. So a few recent therapeutic wins. What's working recently with clients with chemical exposure, chemical sensitivities, is the aldehyde pathway. So I went down a whole trail of research on this, and the ALDH gene, aldehyde dehydrogenase 2, it detoxifies alcohol, so it converts aldehydes into acetic acid, basically. And but guess what? The ALDH gene is also heavily involved in generating NADPH, which is what the body uses for redox signaling. That's your electron donor. That's to regenerate your glutathione. And ALDH is also involved in vitamin A metabolism, making retinoic acid. So, I mean, what could possibly go wrong in that pathway, right? So there's been some products that certain companies have created that are marketing to people to drink alcohol to prevent hangovers. Well, it turns out that these same products, like vitamin B1 and alpha-lipoic acid and molybdenum, they all act, and then herbs like Andrographis paniculata, they all can act on the ALDH gene to stimulate. That's why they can, quote unquote, help to prevent hangovers, is because they're detoxifying the aldehydes. So you can support the aldehyde pathway by using some of these nutrients. That and sauna therapy. If somebody has chemical sensitivities, if they smell chemicals, the things to be thinking about are, yes, there's chemical exposure, but they're having hepatic issues. It's oftentimes one of the things. It's oftentimes their carpets or new furniture is off-gassing formaldehyde, and that's causing an acetylation problem or triggering an acetylation problem in the liver. I have a relative who went to IKEA, bought some new furniture, and started to have some sorts of kind of recurrent mold symptoms. But it turns out that it wasn't mold. It was she got a formaldehyde meter on Amazon for like $50 or less, and found that there was detectable levels of formaldehyde coming off of the new furniture. So she took it back, ran the air filters, and it cleared up the problem. So who's looking at the possibility that the client's new furniture from IKEA is making them sick? So these are the kinds of things that you got to like pull out somehow, right? So an environmental detective. All right, so let's get into EMF Wi-Fi. I know I'm going quickly, but I got a lot of slides to get through here. So just as a summary, you can read this in that 7 Mechanisms of Clinical Investigation PDF. Again, that's in the chat. Download it. Disruption of microRNAs, so DNA damage. This is the big problem. And 5G has been implemented now in major cities. You can use these meters. Nick Pineault recently sent out an email, and he recommended the use of this meter here, if you can see. I bought this for about $150, but it's a basic meter that will just detect the levels of radio frequency that are coming off of things. And surprisingly, the smart meter isn't that big of a deal in most cases if there's a metal box that's surrounding it and the smart meter is not facing the home. If it's not facing the home, it's projecting out. And I've not actually found anywhere. There's smart meters on the front of the property, and they're actually not causing an issue. But what is causing an issue is the actual Wi-Fi router itself, even though it's not on. I don't have my Wi-Fi on. I don't use Wi-Fi usually. So the meter can be very useful at helping to detect the problem. The reality is that if you've got clients with chronic illness, you've got to evaluate if they're EMF sensitive. You need to figure that out. And what I found is that people that have structural conditions like EDS, Ehlers-Danlos, joint hypermobility, as well as people with Lyme and mold, again, I view Lyme and mold as connective tissue problems because they infect and they damage the ECM and the connective tissue. I've found that these people tend to be more hypersensitive to EMF and Wi-Fi. So you need to be looking for that. So here's some of the stuff on the intake to be looking at. People are sleeping with Wi-Fi routers in their bedroom or under the bed or within 5 feet of where their head is, sleeping for 8 hours. To me, that's insanity. And how I just can't even think of how anybody could not think that that's a problem. It's like it's like we've gone back 75 years and we think it's okay to be smoking indoors on an airplane, chain smoking on an airplane for a 6-hour flight. It's just like, who thought that that was a good idea, that that was not a problem? It seems like with the Wi-Fi issue, we're kind of at the same level of stupidity. I mean, I can go on about this, but you probably, the bottom line is you need to be just looking at these things. And I've become so sensitive to artificial lighting. It's not only about screens anymore. It's when you're driving at night, I cannot even look at the oncoming traffic. It blinds me. I can close my eyes. I can still see the imprint of the light in my field of vision. So I'm wearing blue blocking glasses at night when I'm driving because my eyes are so sensitive to that high intensity blue light that they're using now in cars. So we know that blue light directly affects melatonin and melanospin in the eyes. So these are major problems because anxiety and sleep disorders are rampant. So some basic things to be looking at. Got to be looking at the Wi-Fi EMF issue with all clients. Okay, so pathogenic. We're gonna get through this here. So symptoms of Lyme disease. When you're dealing with pathogens, I want to say that I'm going to present my shtick and spiel on why I think stool testing for pathogens may be not really that important. I know there's a lot of people that are going to really, really hate what I just said, but I don't mind being controversial, and I'll get into why I believe that. But when it comes to Lyme disease and the stealth co-infections like Bartonella and Babesia, these kinds of bugs are next level bugs. There's evidence that Lyme is some sort of a bioweapon, and that's not even a conspiracy theory anymore. Mainstream science writers are now writing about that. There's evidence of that, having gone back in the 70s at Fort Detrick, Maryland, and Plum Island, New York. But the reality is that these bugs are so stealth and can cause so many problems. And yes, it's true. Some people are infected with Lyme and are asymptomatic. And there are others that are infected with it and are symptomatic immediately. So there's clearly nobody that's yet studying the outliers, why people that are infected don't show symptoms and why there's other people that do. Is it genetics? I think a lot of it can come down to the connective tissue and the ECM because these bugs infect and occupy the connective tissue. And people that are already hypermobile, I've just observed that they, more often than not, if they have Lyme, they get total breakdown of everything. But we need to study the outliers more, find out what it is about the people that don't get the symptoms but have positive tests for Lyme, what is it that's making them well? So, but the keys to remember here is that remember that most people with Lyme never even recall a tick bite, or they didn't even develop a bullseye rash had they gotten a tick bite. And there's so many symptoms that can overlap with other conditions. The other problem is that the antibody tests that they use are so often just worthless. Even IGeneX doesn't always positively detect. I've played with Armin Labs. I found inconclusive. So it just, can we at least establish the possibility that Lyme is on the radar? And this is just a simple set of intake questions that you can be looking at that could alert you to that possibility. Bartonella is another one of these intracellular pathogenic infections. It does infect the red blood cells. So do the other, Babesia, Lyme, and Bartonella. One of the things I'm looking for is spleen enlargement. Spleen enlargement. This has been shown in the literature to be caused by these bugs. And so I can have the client literally on the call palpate the left side of the abdomen just around the rib cage. Does it feel tender or swollen here? Again, because the red blood cells get broken down in the spleen, right? I think that what happens is that you've got intra-organ toxicity where the bugs are in the spleen, or there's some sort of an immune response being, activated in the spleen and in the reticuloendothelial system in the liver and gallbladder. So you need you need to be looking at these variables. But finding the Bartonella has been a challenge. But having found it in certain clients, using the PCR test from DNA Connections is shown to be very, very valuable. So that's just the new kid on the block at the moment I'll talk about that, is the DNA Connections polymerase chain reaction test. You do a deep tissue massage 1 to 2 hours before the urine collection, and then you urinate after the massage. And that shows to really, really produce positive results where other methods have failed to detect it. Because it's a PCR test, the DNA is showing up. Now, there's oftentimes inconclusive results even on the PCR, or the amplification techniques that they use at the lab doesn't get the total confirmation. So, but if the symptoms line up, what I'll have them do, just to establish this, the Byron White herbs are really powerful. And I don't know if who's listening has an account with that company, but they are really, really strong, and you only go with a single drop. So that can also be used to evaluate the probability of it. But whatever the case may be, you're wanting to look at this. And if you're a physician or work with a physician, if you're dealing with these bugs and they're Lyme literate, you need to really consider referring them to that clinician. Unfortunately, even the Lyme literate doctors, from my experience, are not addressing the whole person. And the longer somebody has had these bugs in their body, the less it becomes about the bugs, the more it becomes about bringing the physiology back into a state of equilibrium. Because you'll start to see total imbalances in cell membrane inflammation, you'll start to see neurological symptoms, you'll start to see endocrine, cardiovascular problems, and these other things are all the downstream effects. And once you kind of bring these systems back online, you don't even need to treat the bugs in many cases. I've had clients test for Bartonella, and okay, so what? You look at everything else that's going on, and as soon as you start addressing it, but they start to get better. So what's recently working with clients? So a few things of interest. First of all, I don't treat Lyme disease. I help people to help themselves to improve their own health. The healer is within each person. I really believe that. And a person's own physiology in their nervous system is equipped to being able to handle complex illness. I believe that. And when we get into breathing exercises in week, I think that's 3 or 4, I'm going to show you what I've been finding with clients, that we can control the physiology by controlling the respiratory process. And I've got some new emerging theories that are coming out. But for now, understand that if you're dealing with a client that has these Lyme bugs, you've got to support the foundations of health. It's being overlooked, and people are trying to only treat the bugs. And when they only try to go after the bugs, the client usually collapses, gets sick, or it's iatrogenic. So the overuse of antibiotics in chronic Lyme causes a mitochondrial shutdown, just total dysregulation. And I'm not saying that I have the solution here, but I'm saying that in many cases, the person their health will be restored without even addressing the bug. For acute infections within 6 months, okay, maybe you use doxycycline if it's been a recent infection. But beyond that point, I don't believe that the antibiotics are that effective anymore. I think it only causes collateral damage in most cases. And so, but again, you've got to really assess the person where they're at and see the whole picture. And that's what's really important about these 7 mechanisms, is that we're trying to evaluate all of the things that are going on that are disrupting the physiology and pulling it all together. So I found that addressing oxalates with Lyme and Bartonella has been a significant new discovery. And I can't say that everybody with Lyme or Bartonella has oxalate problems. I'm not saying that. But I've found oxalate problems to show up in people with Lyme and Bartonella, and addressing those opens up the detox pathways, because oxalates will compete with sulfate. Sulfation is critical for all detoxification processes, especially hepatic. I've also found that people with Lyme and co-infections often have detoxification pathway problems. Somehow it's not working right. There's been problems. Maybe they've had gallstones before, or they have spleen pain or hepatic pain or constant bloating in SIBO that is possibly related to a bile acid deficiency. But these problems show up over and over again. So I've developed a therapeutic sequence that I found to be useful is using the Quicksilver push-catch protocol followed by hyperventilation and breathing techniques, because there's evidence from the Wim Hof study from 2014 that hyperventilation inhibits the innate immune response. And there's evidence clinically that it can inhibit the Herxheimer reaction. If they're taking herbs or antibiotics, you can practice breathing. You can teach them to practice breathing techniques, and that can have a direct effect on their autonomic nervous system and on their innate immune system. I've seen how it can mitigate herxing, despite taking the herbs that they're herxing on the previous days. So the Byron White formulas, if I do use those or have used those have shown to be useful, but only in combination with something that stimulates the hepatic system and flushes out, the intestines and the hepatic system. Coffee enemas, I don't know what your opinion is, but I've found them to be valuable over the last decade. I've had many people report how amazing they've been, and I've witnessed their possible effects. I've had clients tell me that they would take the A-bark single drop and they'd herx huge, for 2 days. But if they did the coffee enema and the push catch, they were fine. I've had people tell me that. So the breathing techniques added to that has been the newest component that has shown me that, wow, we can control our Th1 innate immune. We can control the inflammatory response. We can control TNF-alpha and these inflammatory cytokines by hyperventilating. It's been proven. It's been established in the literature. Let's implement it. Let's start using it. Yes, I'm on board. So those are some wins there. Now, I want to get into the whole GI pathogen issue. And I realize I'm going to raise some eyebrows here. Here he goes again. But I'm not totally on board that stool pathogen testing is necessary or even useful. And there's some good stool tests now. We can run the GI map test. That's a PCR test. We can establish the presence of multiple parasites. But what about immune tolerance? And this is an issue that I want to really hit. And I talked about this on the webinar last week, but I want to bring it up now. This is the situation that I've seen repeatedly now. Disease-causing pathogens detected on PCR-based stool tests, yet the client exhibits no disease symptoms whatsoever. I'm talking about Giardia. I'm talking about Entamoeba histolytica, so-called virulent pathogens. But where are all the symptoms? None. What's going on here? Why? Well, as you start to dig into what is regulating the gastrointestinal immune response, you're dealing with the body's own mechanisms that control what bugs are doing. So we know from some of the more recent microbiome diversity research that it's now about kind of controlling the keystone strains, such as Akkermansia muciniphila, Bifidobacterium, and Fecalbacterium protsnitzi. These are what are known as keystone strains. And there's a whole microbiology theory about keystone strains. If you try to eradicate a single pathogen using an antibiotic or even an antimicrobial, there's no way that you're not going to also create collateral damage and disrupt the delicate ecological balance between microbes in the gut. Everything is going to be disrupted. It's a holistic system that's in check. You're going to try to go in there and kill just Clostridium difficile? Good luck. You're going to wipe everything out. So, and it should also point out that, well, why is the most effective treatment for C. diff a fecal transplant where you're importing billions of bacteria in the intestines with feces? How is that the most effective treatment for C. diff? Shouldn't that alert you that the problem is in the actual microbial ecosystem of the gut, that something is off, that we have to control these mechanisms as a primary? I mean, it seems like we need to really be looking at these things more closely. But there's other factors that will influence the GI immune response. So the oral tolerance factors, for example. TGF beta signaling in the FOXP3 transcription factors, T regulatory cells, or Treg cells. These control how the immune system responds to bugs. There's a paper titled TGF beta, master regulator of the gut microbiota. Who's looking at this? This is the thing, is that when you run a stool test that detects all these pathogens, nobody's looking at what all of these things are doing. How is TGF beta or Tregs affecting, or how is the vagus nerve, which is through its acetylcholine signaling, regulating the cytokine inflammatory response? The stool test can't show these things. But the reality is that these are the mechanisms that control our immune system's response. Because most of the symptoms that you experience, or your clients experience, most of those symptoms from so-called pathogens are your own immune response to the bugs. Now, maybe the exception could be lipopolysaccharides from gram-negative bacteria. Okay, take a little activated charcoal. But again, we have to look or use microbial balance theory. So we have to really be more holistic in the way we're looking at this. Otherwise, we risk being Pasteur-based allopathic, right? So we have to move into the 21st century with how we're viewing pathogens. This is a fascinating study. When eradicating parasites may be a bad idea. If you've not read the book, The Dirt Cure, read about what happened when they went to Africa, treated the kids with antiparasitics, and the kids all developed eczema, psoriasis, and asthma as a result. How is that possible? Maybe the parasites were doing something beneficial to the immune system. Well, it turns out that parasites are powerful Th2 promoters. They're anti-inflammatory, and this is a case of multiple sclerosis, a Th1 dominant autoimmune disease. Previously, we demonstrated that Helminth-infected multiple sclerosis patients showed significantly lower number of relapses, reduced disability scores, and lower MRI brain activity compared to uninfected subjects. In the current study, 12 patients with the diagnosis of remitting MS presenting parasite infections were prospectively followed up during 90 months. Due to the exacerbation of the Helminth infection symptoms, so it did cause symptoms for these people, 4 patients received antiparasitic treatment. Helminth infection control, so eradicating the bugs, the parasites, was associated with significant increase in clinical and radiological MS activities. The MS got worse when they killed the parasites. Moreover, these patients showed significant increases in the numbers of inflammatory interferon gamma and interleukin-12 producing cells, and a fall in the number of TGF beta and interleukin-10 Th2 cytokine system, as well as the T regulatory system after the anti-Helminth therapy. These new observations on parasite infections associated with MS indicate that parasite regulation of host immunity can alter the course of multiple sclerosis. So everything we thought we knew about bugs it needs to be revised and looked at differently. We need more data and evidence on these regulatory mechanisms of how our own body is responding. Not only that, but what we thought we knew about parasites may be wrong. And it may be wrong, especially if you're working with a patient with Th1-based autoimmunity. So here's a number of genetic variables that can influence the gut microbiome. And here, this is our new nutrigenomics report is going to have a number of new updates, so you'll be able to run that. The TGF beta and the FOXP3 transcription factors are there in the report. So a lot of these, the FUT2 non-secretor genotype, that can alter the levels of bifidobacterium in the gut, so it can adversely affect the keystone strain stuff. It can also increase virulence of H. pylori. So there can be genetic variants that are affecting the host to microbiome interaction. So I'm not going to present all this data on what can we use to kill bugs. I'm going to rather present data on what we can do to promote immune tolerance and gut microbial modification. Because to me, this is the bigger issue that we need to be looking at. So short-chain fatty acids, increased diversity in the gut, can help to increase TGF beta, which is an anti-inflammatory cytokine, as well as Th2 promoting interleukin-2, and then the antibody system, as well as Tregs. So SCFAs, so we get this from fiber, right? And especially from resistant starch. You can use the prebiotics, inulin and FOSs. Microbiome Labs has a good prebiotic that's out right now that's not even derived from that. It's derived from other sources of oligosaccharides. So SCFAs. Oh, I should also mention butter, of course, is a source of SCFAs. You can't have a conversation about the gut without talking about Lactobacillus reuteri, as there's plenty of studies that have shown the beneficial effects of immune tolerance and Tregs promotion using reuteri, inhibiting autoinflammatory Th17. So you know about Th1 and Th2, but know that Th17 is the autoimmune arm. And Bacillus subtilis, there's a good number of studies. Microbiome Labs has a great product on Bacillus subtilis. So it's a spore-based probiotic. They have great product that they formulated, but there's good studies on that. Also, so remember that T regulatory cells are Treg cells. These are the most anti-inflammatory T cells that come in and say, calling off the shots. Ceasefire, ceasefire, ceasefire. Those are your Tregs. We're stopping the inflammation right here. End. That's T regulatory cells. So everything I'm referencing about Tregs, this, Tregs, that, it's all promoting this anti-inflammatory T cell that comes in and shuts down the inflammatory process. So that's why that's on this page. So serum bovine immunoglobulins, so you're actually taking orally IgA, IgG, IgM antibodies. This is what they've been shown to do. So tolerogenic dendritic cells and interleukin 10. And high protein diet will incite bacteroid fragilis polysaccharides. So this is a beneficial phyla that can increase the Tregs as well as inhibit Th17. Okay, I'm going to take a sip of water. How you guys doing? All right? I know I'm spewing here, but we will get through all of these slides. So trauma is the next thing here. So when you're assessing trauma, again, I want to really, really caution that you don't just come out and say, hey, have you had any traumatic childhood experiences? That can set off trauma. So you're not going to find trauma on your client intake doc. This is something that the client will tell you if they're comfortable with it, if they're ready to reveal that to you. You can also kind of get a sense if trauma has been a factor, if there's anything about their personality that may tip you off. So for example, maybe they have anxiety disorder. Let's look at the ACE score, because that to me is what's really relevant here. So you got to really carefully recognize this. If they have eating disorders, if they're unstable emotionally, if they feel or seem like they're emotionally guarded or protected in some way, these could be indicators that they've dealt with trauma. But the reality is that trauma has a profound effect on the brain and the nervous system, and it has to be addressed in chronic illness. It has to be eventually discovered, and something needs to be done about it. And I'm going to give you some things that I found to be useful, as well as a roadmap going forward about what we can be looking at. So this is a useful slide just to kind of get a sense of. Moving on. So again, I choose not to use the intake forms, have them write it out in the story, and when they feel safe, they'll reveal it to you. So let's talk about this. So the ACE score, you know about the ACE score, adverse childhood events? So this was a population-based study that looked at 17,000 middle-class Americans from the United States. And this was the racial breakdown. 80% Caucasian, 10% African-American, 10% Asian. The average age was 57, and it was almost 50-50 male to female. And what they did is that they compared adverse childhood events with various health status parameters. And what they found was astounding. And so this is the link, just if you want to put this up. If you feel comfortable with sending this to your client, it's acestoohigh.com. That's acestoohigh.com. And that's got your ACE score. It's a simple 20 question evaluation that gives you an ACE score. Basically, when you have an ACE score that's 4 or higher, this is the population data from Dr. Felitti, as you see the source there. This was a study published 2004. Really remarkable how an A score of 4 or higher is strongly linked to, you could just see the curve going up and up. So with smoking, there's the association with chronic obstructive pulmonary disease, with alcoholism, 4 or more, childhood trauma and associations with, here's more A score stuff, adult alcoholism, rates of antidepressant prescription use. Look at this, 4 and 5 or higher. Astounding. Chronic depression, risk of perpetrating domestic violence. There's actually more, and there's more studies that have been published on different disease associations. There's many disease associations with the A score. So the question sort of remains is, well, what is the kind of pathophysiology behind how the A score is affecting, how trauma is affecting the brain and the nervous system? And we have to defer first to Dr. Stephen Porges's work when talking about this. So the polyvagal theory, so Dr. Porges is a brilliant scientist in the United States, and he's basically, this is like revised Darwinism, right? This is taking it to the next level of how the autonomic nervous system is involved in chronic disease, and how the autonomic nervous system responds to the threat of danger. And basically, according to the polyvagal theory, there are 3 branches of the nervous system, and their functions are the freeze and immobilization state. So it's not just fight, flight, it's fight, flight, or freeze. And then the fight or flight is number 2, as we know, the sympathetic response, which gets activated in trauma. As he says, when a person has a reaction or response to trauma, the body interprets that traumatic event as a life threat. And as a life threat, the body goes into danger mode, protection mode. There's an immobilization that can occur, when that takes such a toll. But then the third part is the social engagement safety aspect, which is the perception of the ventral vagus complex. The ventral vagus nerve is integrally involved in this safety valve component of how the nervous system is perceiving danger. So there's 2 branches of the vagus nerve. There's the dorsal and the ventral branch. When you're dealing with clients with chronic illness, you've got to hypothesize the probability of vagal nerve involvement. And I'll be honest with you, we don't have many great mechanisms yet of directly evaluating the vagus, because the vagus is involved in so many physiological processes. It's really difficult to isolate what it's not involved in. But like the entire digestive tract has different branches that relate out to the dorsal vagus complex. So there's been talk about, we know, for example, that gastroparesis is a major dorsal vagal problem. Postural orthostatic tachycardia most likely involves vagal atrophy on some level, or vagal dysfunction on some level. But the ventral vagus is the upper branch of the vagus towards the head that controls the esophagus, the bronchi, the heart, the pharynx, and the larynx. So speaking, swallowing, and the cardiac sinus rhythm. So arrhythmia, the sinoatrial node of the heart is controlled by the ventral vagus signaling. So the vagus, there's afferent and efferent signaling. So it's basically the vagus is communicating with the brain, and the brain communicating with the rest of the body via the vagus. So it's this bidirectional control circuit that is getting feedback from and to the brain. And when this becomes disrupted is when we start to see problems. Now, it turns out that the vagus nerve is doing other things that are really significant. So we know that the parasympathetic nervous system, rest, digest, safety, healing, cardiac sinus rhythm. Guess what? The vagus nerve has a powerful effect on the immune system. And so T-cell mobilization from the gut lymphoid tissue is one of the major functions of the vagus. The differentiation of macrophages in the gut. So the movement of immune cells and the formation of new immune cells is something that acetylcholine signaling via the vagus nerve is doing. So think about that in the context of autoimmune disease or any disease involving the immune system. Any disease involving the immune system has to, on some level, involve the vagus nerve. It's powerful. So it's not only, it's not single directional, it's bidirectional. It's the vagus is sending signals to and from the brain and the periphery of the brain. So the cell danger response meets the vagus nerve. So meet Dr. Robert Navio, who in my opinion is one of the most important scientists today, developed a new systems biology to chronic disease. If you've not read the papers, please read the metabolic features of the cell danger response published 5 years ago, and then read the recent paper just published recently, Metabolic Features of the Healing Cycle, a new model for disease pathogenesis and treatment. Those papers are so rich with unbelievable information that is going to just open it all up. And from a clinical standpoint, what we can now look at are how we can sort of evaluate the probability of a cell danger response occurring. And what Navio has alluded to in his recent paper is that there are 3 phases of the cell danger response. And he's now calling the cell danger response the healing cycle, because it's essentially the body's protective mechanism when it perceives danger, how the physiology and how the cellular structure responds to this threat of danger. And so it largely involves the mitochondria of the cells and the extracellular ATP. The ATP gets thrown into the extracellular environment and becomes a neurotransmitter that coordinates with the immune system. So people get stuck in CDR1, CDR2, or CDR3, and he, in his new paper, has elaborated on over 100 diseases that involve the cell danger response. Profound, astounding. So, but it turns out that during cell danger response 1 and 2, CDR1 and 2, the ventral and dorsal vagus loses their coordination and are directly involved. So the HRV will drop, for example. The HRV drops suddenly, heart rate variability drops, there's a possible cell danger response that's occurring, and so we need to be aware of that. So how does this help you clinically? So first of all, again, I want to say that we need better and more we need more conclusive, definitive vagus evaluations, but we have a few things we can use now. So the gag reflex, you could stick your finger in the back of the throat, teach your client to do this, and if they don't gag, if they have a no gag reflex, then it's a possible vagus nerve deficiency. It's more probable. The uvula asymmetrical assessment. So the exercise is basically this. You have the client open their mouth and they go and the uvula should move up and down in a symmetrical line. And if it's asymmetrical, if it's moving, that's either a 9th or 10th cranial nerve problem. The vagus is the 10th cranial nerve. So this is one thing to be looking out for. People that have had head trauma, concussions, you better believe that the vagus is going to be involved. If they have cervical cranial instability, where the first and second vertebrae are out of alignment, what Stanley Rosenberg in his great book, Accessing the Healing Power of My Vagus Nerve, somewhere on that shelf back there, phenomenal book, Accessing the Healing Power of the Vagus Nerve by Stanley Rosenberg. He had his students place their fingers on his transverse processes of his first and second vertebrae in his neck. And he induced a single negative thought that negatively affected his mind. That single negative thought caused a subluxation of the first and second vertebrae in his neck, which pushes against the ventral vagus because they run adjacent. And it has a subtle but significant effect. That's why you see in trauma, people often have forward head posture, because the forward head posture is part of that startle response, that fight or flight response. That was first pointed out to me in Tom Meyer's book, Anatomy Trains, 15, 17 years ago. But we know that, so that's another thing, is that if that cervical spine is significantly misaligned, or if there are cervical issues that are prominent, you've got to be thinking about the effect that that's having on the ventral vagus. And consequently, that can be creating all kinds of problems. So let's look at some potential practices that are of potential value. So I want to also say that when you're working with clients that have trauma issues and or vagus nerve issues that are suspected or known, the first thing that needs to be established is a feeling of safety. I call this safety sensing. And this is something that it's important for you as the practitioner to communicate with the client. So one of the ways that you can do this is to connect on a heart level with the client, not intellectually like we're used to, but actually on a heart level with the client. Talk to them, feel what they're feeling, and take them in. Give them space just simply give them space, if you know what I mean, and create a feeling of safety. And you can even reaffirm and say, I want to tell you that I'm really sorry that you're experiencing these things. And I want to tell you that you can feel safe with me. These things, these reaffirmations are very, very powerful. And to actually embrace this yourself establishes this deeper level of trust and safety between you and the practitioner. Between you and the client or patient. Instead of this sort of dualistic relationship that's often established in these sterile medical environments where, Nurse Ratched comes in and writes on her notebook, or the doctor comes in and is just very, very cold and demanding and authoritarian and objectifying, and this is the way that it is. This is the BS that's happening in the majority of medicine today. But if you can connect on a level that's very personal and embracing, again, the practitioner has to create the feeling of safety, because it's the feeling of safety that will help the client to feel safe themselves and to know what that feels like. Somebody that's had severe trauma may not know what it's like to feel safe, because they may feel that they're in a perpetual state of danger, and they just think that that's normal. So I hope that resonates with you. So creating felt sensing and creating the feeling of safety is the prerequisite. So biodynamic craniosacral touch. So this is not the same thing as biomechanical craniosacral done by an osteopath or by somebody that practices biomechanical, where they're fixing fulcra, they're fixing pathological. That therapy is okay. But biodynamic is a more subtle practice that doesn't involve technique, and it involves connecting heart to heart, wisdom to wisdom with the patient. And it's basically the feeling of communicating touch. This is felt sensing. This is touch sensing. This communicates non-verbally to the nervous system of the person. You're communicating non-verbally from nervous system to nervous system, the feeling of safety. And I can't tell you how powerful that is. It's so utterly powerful. And to experience that yourself, go and find somebody that does this kind of work, because it's so incredible. If you can experience that, you can then refer them to somebody like that. But this has been showing to be extremely valuable. Breathing exercises, proven to affect the vagus nerve. When you do hyperventilation techniques, which is you're actually creating a hypoxic state, temporary suspension of oxygen delivery to the tissues, because the oxygen and the hemoglobin bind very tightly. What happens is that this raises the levels of carbon dioxide in the blood. I'm sorry, prolonged exhalation does that. What the hyperventilation does is it stimulates, let's not talk about hyperventilation. I wanted to talk about that later. I'm talking about prolonged exhalation. Sorry, got confused. Prolonged exhalation is when you're breathing out, making your exhale twice as long as your inhale. And that raises the levels of carbon dioxide in the blood. Carbon dioxide is a powerful sedative agent that stimulates the vagus nerve. And there's research on that. Carbon dioxide deficiency is probably occurring in a vastly underreported number of people. We know it's occurring in hypothyroidism. And there's been studies that showed that. Asthma attack features carbon dioxide deficiency. There's other issues that are probably affecting low levels of carbon dioxide in the blood, and that's causing problems. So we can actually increase these levels volitionally with our own breathing. Exposure to cold, positive social relationships, all have been known to stimulate the vagus. Meditation, trauma release therapy, yoga, stimulate the vagus. Again, felt sensing, touch sensing, creating the feeling of safety. Neurofeedback has been shown effective for childhood trauma. EMDR is more effective for adult trauma, like PTSD from adulthood, not childhood. EMDR is the eye movement desensitization technique. You could use acetylcholine for motion therapy, like alpha-GPC, huperzine A, and DMAE. Huperzine A inhibits acetylcholinesterase, the enzyme that breaks down acetylcholine. Remember, acetylcholine is the primary neurotransmitter of the vagus. Caution using anticholinergics and antihistamines because they inhibit acetylcholine. Now, controversial, taboo, but there's now emerging research on the effects of various entheogens and psychedelics. It's now starting to slowly being used in mainstream. There's research that's emerging on MDMA and ketamine for the treatment of PTSD and anxiety disorders. Low-dose psilocybin is undergoing trials for resilient depression. A lot of these entheogens will act on the tryptophan pathway, the serotonin system, but they can act in more powerful ways because they can create imprinting in the brain and nervous system. Having been listening to what people have been experiencing in psychedelic circles, people that have been doing work on themselves, not recreational use of party drug stuff, but actually using these plant medicines as a way to heal. I've heard some unbelievable stories, remarkable stories that deserve much closer investigation and potential use. So these are things that are needing to be looked at in the future. Roadmap going forward, as I should say. Okay, take another sip of water. And a breath of air, because it's always good to breathe. Okay, so structural issues, where are we at? So we're getting through it. So connective tissue problems, EDS, injuries. So potential, we have to take inventory. So looking at the 7 mechanisms, we just want to kind of pull these out. Has there been any injuries or surgeries? And how is that affecting them? So if you forgot that the client had gallbladder removed 20 years ago, well, maybe they need to be on bile acids. Maybe they need to have digestive support. So it's important to pull these things out. So if you've had hysterectomy, this could predispose you to Alzheimer's and dementia, especially if it's done before the age of 40. There's evidence of that in the literature. Surgical implants, titanium rods, metal, bioincompatible metals. Again, I've had clients say that, oh my God, I took the screws out of my leg and I feel so much better. Great. I mean, it tells you that the metals can be a problem. Tonsil removal and effects on the lymphatic system, car accidents, PTSD. So these are some of the obvious impacts that surgeries could have. Traumatic brain injuries. There's a strong association with Alzheimer's and dementia. Neuroendocrine disruption, anxiety, depression, psychiatric problems, increased risk for substance abuse if you've had TBIs. So we've got to be taking inventory of these things, right? Because this is neurology. Now, you may not be a neurologist or specialize in neurology, but you can automatically start thinking about and hypothesizing about how has the 3 TBIs that my client experienced at the age of 25 affected their Parkinson's disease 25 years later, or their sudden onset adult anxiety disorder where they suddenly show a cortisol level of over 1,000. You got to start thinking about these things because they're playing out, and there's evidence in the literature that's published that shows that they're playing out. Let's talk about connective tissue and EDS, my favorite category. And if you haven't read the June 2019 edition of the Townsend Letter, my article is in there. So I sent it to Dr. Collin, and he published it last month, and I was very honored to have that. You can read my more extensive theory in that, and Scott Forsgren and team, I thank you very much for having me present at the TFIM conference on this important overlooked subject of joint hypermobility and the extracellular matrix. But the 2 things that I want you to really know when you're evaluating hypermobility syndromes in your clients is, number 1, is this an acquired hypermobility? In other words, did it suddenly appear as a result of some illness? They suddenly got sick and they became more hypermobile? There are people like that. Or is it genetic? Have they had this their whole life? Or are there family members that have it? You've got to really differentiate between the 2. Here's why. This is a study published last year on Bartonella. This is a veterinarian who showed the symptoms of type 3 EDS, Ehlers-Danlos syndrome, type 3, the most severe form, causing a shortened lifespan. You'll die before the age of 35 because of your vascular system. Guess what? It wasn't EDS type 3. She was infected with Bartonella from fleas because she was dealing with animals all day. She had a hypermobility score of 7 out of 9, and after the treatment with the antibiotics, 0 hypermobility. It went away. So Bartonella infects the connective tissue, causes breakdown of the ECM. I think it's a cell danger response happening in the fibroblast cells that produce the matrix. That's just my theory. Nobody's proven that yet. But what does joint hypermobility actually look like? So here, this is a really useful, I'm going to show you the Baton scale, 9-point scoring scale. This will take you all but 20 seconds to do this, either in your office or you do this on a video call with the client, which is what I do. So this is just to get a baseline assessment. So this is number 1, the pinky test. So everybody do this. Put your pinky down, face down on a table, and with the palm laying flat, obviously you can see the imaginary table below me. If the pinky finger extends past the 90-degree angle, that's 1 for each hand. So I can't do that. I'm not even at 90 degrees, but you can see here if they can, that is 1 for each hand. Next is the thumb assessment. So thumb to forearm. Hopefully you can see me there. I can't do it, but if you could touch the thumb to the forearm, that's 1 for each thumb. And then the elbow test, palm up. If the elbow outstretches beyond 10 degrees between the normal outstretched position, that's 1 for each side, for each arm. And then if the knee is standing straight, if the knees hyperextend, that's 1 for each leg. And then last but not least, I don't know if this one is as effective because most people can, through let's say like yoga, can develop very flexible hamstrings. So, but if they can do it, palms to the floor with legs straight, knees straight, then it's 1 point. So that's the Baton scale 9-point scoring system to evaluate hypermobility. Sometimes the client doesn't even know what hypermobility is. And I send him this. I said, go do this, or just run it through on the initial call just to see. And why is that important? Why do we need to understand, before we get into that, why do we need to understand the importance of hypermobility? Because it's not so much just about whether or not they're hypermobile. Because usually what you'll find is that people that are hypermobile have multiple health problems going on. Not always, but oftentimes, people that have a high Baton score have multiple comorbidities. Autoimmunity, POTS, mast cells activation, all kinds of, I mean, it's unbelievable. Some of the sickest people in the population, it's almost insane when you look at it. It's just like, how can this be? But it's more, there's more going on than just the hypermobility component. It's the extracellular matrix. And the extracellular matrix plays a vital role in the regulation of the physiology, the regulation of the immune system through cytokine trafficking and cytokine signaling. And the extracellular matrix binds to and activates a number of important growth factors, right? The TGF-beta growth factor that we talked about, that's activated in the tenaskins, in the extracellular matrix. Insulin growth factor 1, IGF-1, is activated in order to activate your growth hormone. That's activated at the integrin level, the cell-to-tissue interface. So a lot of these growth factors are activated by the connective tissue. So there's many things that will be disrupted when a person has weak connective tissue hypermobility, which is just the tip of the iceberg, right? So that's what you're looking to assess the tip of the iceberg. Can I see the tip of the iceberg on this client? Yeah, look I see an iceberg just kind of peering out from the water. Well, but you don't see everything underneath it, or now you're starting to see that there's a huge, mountain underneath the water. Okay, upper airway palatal issues. Airway restriction, improper breathing. How is this? This is so overlooked, it's ridiculous. So are you assessing whether or not your client is a regular mouth breather? Can you hear in their tonal voice that they're breathing in their upper sinuses like this? That could be a breathing problem. That can be an upper airway restriction problem, which may be a connective tissue related problem. But the thing is that these airway restriction problems can reduce oxygen intake. Read the scientific literature. There's plenty of published information about this. But this is one of the structural issues that I'm looking for. We often forget how important oxygen is, right? Because, well, we're breathing all the time, right? So we don't think about, oh, did I take the time to breathe today? What the hell does that mean? Because I'm breathing all the time, unconsciously, right? But in a very real sense, every mitochondria that are in your body, how many quadrillion is that? An infinitesimal number of mitochondria burn oxygen as a catalyst for ATP production. So that tells you how important oxygen is. But it's the overlooked thing. We're looking at everything else, but the elephant in the room is oxygen. Everything is dependent on oxygen. So that oxygen CO2 exchange that's so vital for the blood pH and for everything to work, it's going to be off if there's upper airway problems or if there's airway restriction or breathing problems. So how can this not be a problem? I mean, everything is going to be affected, right? And so that's why there's association-based studies that show that airway restriction is associated with sleep apnea, with anxiety and depression disorders, and you can just find a whole list of things. A lot of the neuropathy symptoms that you'll see, the peripheral neuropathy symptoms, and the blue discoloration of the tips of the fingers, and the capillary hypoperfusion, that's all involving oxygen dysregulation. Granted, those conditions are caused by mold or SIRS or an inflammation, but it shows you how things can become disrupted when oxygen is disrupted. That's just the tip of the iceberg. So I'm really excited about the breathing stuff to share with you week 4, because I think it's one of the keys that no one's looking at. But for now, know that you need to be looking at this. The airway intake problem is huge. And if they have a narrow palate, Dr. Klinghardt was really, 1 year ago today, he was burying on this, on the importance of this, and how acetylcholine to the brain can be improved if you expand the upper palate. Now, I don't know if there's arguments to make about the palatal expansion therapies that certain dentists are using now, because you're affecting the cranium, but I mean, it can be done because the upper palate is connective tissue and it is pliable. So some potential therapeutics. Now, this is just a little kind of teaser, right? Because you can go on for days about this stuff, but just generally for upper cranial and cervical things, you need to think about structural integration. So Rolfing and structural integration therapy has its place. So does nucochiropractic, which focuses just on the upper cervicals. Craniosacral, the osteopathic, biomechanical to literally fix structural imbalances. Remember that if the cervical spine is off, the lymphatics, the lymph drainage from the brain is going to be potentially affected. On Dr. Beelan's Alpha thermodiagnostics device, how common is it to see lymphatic problems with almost everybody today? It's overrepresented. But I'll guarantee you that a lot of these can come back down to cervical problems with the population. There's a chicken embryo supplement that I've been using, derived from Europe, that contains in it a number of growth factors and microRNAs, and it's showing to be very, very valuable. It's called Mega Complex GF, and we use this with our clients. I get it from the distributor directly, and so far, I'm beyond impressed by what I'm seeing. I can spend a lot of time talking about it, but know for now that I'm really looking at this when there's structural and connective tissue problems. For the hypermobility component, this is a really complex area, and it's not just as simple as these 3 things. I'm going to be quite honest with you right there. But these 3 things have been shown to be really useful. I did a poll of the CUSAC forum for EDS several months ago, and they were telling me, these are the people self-treating with EDS and hypermobility themselves. I said, well, what is working? And so some of the things that were really, really significant was, I should have put it on here, but I didn't. Magnesium, electrolytes, high-dose vitamin C, aloe vera, lion's mane. So the lion's mane and the aloe vera contain the polysaccharides. Polysaccharides help to build the collagen up. And vitamin C plays an important role in lysyl oxidase. So just a couple of simple things. It's more complicated than that, but way more complicated than that. Traumatic brain injury. So think about, again, vagus, cranial sacral therapy, hyperbaric oxygen, very useful, especially immediately after. Neuroceuticals. So this is the list of some of the most important neuroceuticals that act on the nervous system. So remember that DHEA is a neurosteroid. We're going to talk about DHEA sulfate in week 3 in the endocrine section. DHEA is not just a promoter of testosterone, it's also feeding the pregnanes and the neurosteroids in the nervous system and neurogenesis and the neurotrophic, very powerful neuron repair. Lion's mane, also useful, acetyl carnitine arginate, that form of carnitine. The L-carnitine arginate form, icosapentaenoic acid, EPA, not DHA, but EPA, citicoline, which is a form of choline, alpha GPC, which promotes growth hormone, B12, nicotinamide adenine dinucleotide riboside, coenzyme Q10. And for airway issues, frenectomy, cutting the frenulum under the tongue, even if you don't have the problem that infants have. I've had clients tell me that their breathing changed when they got the frenectomy, when they cut the frenulum under the tongue. They've told me so many symptoms improved when they cut the frenulum. Amazing. How? I don't know. But I have a dental colleague locally that is adamant about cutting the frenulum, or you just melt the frenulum, I guess. So that could be a huge thing for people. Mouth taping has been shown to be very useful. When you're sleeping, taping your mouth at night, to just breathe through force yourself to breathe through the nose more and not snoring. Dental appliances that can correct the bite, also shown to be very useful. We've got to think about the lymphatics in the brain and the neck, and of course, breathing techniques, which we'll get into week 4. Okay, so we're gonna definitely keep going here. So medical, dental, iatrogenic. Okay. So when you're doing your intake, talking to your client or have your client write it out in a story, because for this, I wouldn't have them fill anything out like a checkbox intake, because there's so many things that could come up. But you want to just kind of look for any drug or any medical procedure, whether it's a vaccine injury or fluoroquinolone toxicity or benzodiazepine withdrawal or opiate addiction or withdrawal. You want to just pull it out and just see, is this going on? Hey, Jimmy, I forgot to tell you, I took a course of Cipro and my life has never been the same since. Or maybe they didn't even associate the Cipro with doing that. But they just, I did do the Cipro. Oh my God, wait, what's Bloxing? I never heard of that before. Wait, fluoroquinolones inhibit topoisomerase in the mitochondria? What? I didn't know that. Yeah, well, guess what? They're mitochondrial toxins. So you want to be able to pull these things out. Has medical injury occurred on some level? And is it contributing to the client's degenerative illness? Dental toxicity. So we know about a number of different dental procedures. We know about the amalgam issue, but it's not just about that. It's about cavitations, root canals, abscesses. Dry sockets are almost always infected. If you had dry sockets after having a tooth extraction or wisdom tooth removal, high probability that there's an infection underlying that. And that can cause TMJ, that can cause all kinds of problems. Incompatible composites, so using metals or using some plastic that's not compatible. And some of these toxicity issues, so biofilm in implants, plastic resins in orthodontures, mixed metals and galvanic toxicity. When the metal touches the saliva, what does that do? Pleomorphic bacteria, strep, Borrelia in the mouth, propionic bacteria, Marcons, which was initially detected in the jaw, I believe, from the Shoemaker research with the dentist. So you're just taking an inventory of these things. Let's talk about genetics, familial associations. So on your intake, you want to just kind of evaluate, what do people have in the family? So autoimmune disease there's a huge genetic component, right? And we can isolate even the genes that are involved if we wanted to. But we wanted to do this because it's leading us to kind of think more about some of these mechanisms. So if there's autoimmune disease in the family and the client has some symptom that could be autoimmune but is never tested with an ANA that's high, you want to at least think about that autoimmunity may be a possibility. Joint hypermobility can run in families. Connective tissue problems can run in families. That could lead to a whole rabbit hole into what that means about the ECM and connective tissue. There are genetic variants that can predispose to cancer, as we'll see. Cardiovascular disease can have genetic components like MTHFR. Type 2 diabetes, there's some mitochondrial variation. So this is just a short list, bullet point, of true mutations that can cause certain true genetic diseases in some way. So the cystic fibrosis gene, the sickle cell anemia gene, APOE44, which is the homozygous for Alzheimer's and vascular disease, the BRCA1 and 2 genes, which can predispose to breast cancer. These are the DNA repair gene. FMR1 for Fragile X, the Huntington's gene, which is a copy number variation gene. And then G6PD, glucose 6-phosphate dehydrogenase, which impairs cellular redox, so regenerating your glutathione. And then Lynch syndrome genetics, which is more common in Eastern Europe, I believe. Predisposes to many different cancers. It's a terrible disease. And that's being caused by DNA genes that are supposed to repair the DNA when there's DNA damages and breakages and things like that. Hemophilia gene, the DMD gene, RCCX, you can read my research on that. And then here's the COL genes that are associated with EDS. So the hemochromatosis one, yeah, that's coming out in our new report. So I just added 70 new SNPs to our genetics report. I spent over 100 hours doing literally reading studies and just pulling apart risk alleles. So these are all new sections that we're adding to our genetics report. This is our True Report software. It's true.report. It'll be available in a couple of weeks. And so we're adding a whole section on oxalates. I'm going to tell you about oxalates more in the food section, lastly, coming up in a few minutes here. And so a whole bunch of new sections that are really relevant. And I'm really excited because when you look at genetic studies, if you're looking at genetic data, if you're looking at genetic data with your clients, if they're sending you the raw data file from 23andMe, let's say, there's some good studies and then there's some not so useful studies. And what I've started to do and really, really dug into more is let's find the really good studies. The really good studies are the ones that say this SNP is associated with a 40% reduction of plasma vitamin A. That's a good study. Or this FADS1 SNP is associated with higher levels of arachidonic acid by 19% on average. That's a really good study because it's telling you the probability of gene expression from that SNP. And oftentimes those SNPs are found in the promoter regions of the gene. So I'm always looking for those kinds of studies because it's giving you data that's saying, hey, guess what? If you're homozygous for these two HFE variants, there's a pretty darn good chance you're going to have, even if you're compound heterozygous, there's a pretty darn good chance you got elevated ferritin. And if you got elevated ferritin is toxic. Let me tell you right now. I don't know about these doctors that are doing iron infusions, but that's insane. I had a client the other day, chronic disease client, and oh yeah, she's got anemia. Let's give her iron infusions. They gave her iron infusions and she crashed. She was so sick from that. I mean, not only do bugs and viruses hijack the iron pathways of our body, but iron oxidizes where it forms Fenton reactions and hydroxyl radicals. There's a reason why hemochromatosis predisposes you to organ damage because iron is toxic. And there's a lot of good clinicians out there that are really talking about this, like Morley Robbins and Bob Miller, and the importance of iron toxicity in chronic illness because it's a big deal. So I've pulled apart a whole section in our report that doesn't only look at HFE, but a bunch of other SNPs that are involved in iron toxicity and iron metabolism. So anyway, some good stuff coming with True Report. And genetics do play a role in disease. But we want to find out how are these variants relevant for my client. And from the initial intake, you don't necessarily need to know all that unless you already have the genetic data and you really, really want to have that by the first consult. But you don't need to. You just, establishing any association, just familial, is often very valuable. Sometimes with the RCCX clients that I work with, or the suspected RCCX clients, the most useful thing is finding out the family history because it's telling me the predispositions. Dietary, let's get into that next. This is our last section. So thank you for holding on, for everybody that's still here. And we're going to do a Q&A here. So hold tight. And I should say, if you got questions, please pop them into the chat now, and we'll get to them in the next 10 minutes. Food compatibility. This is huge. So you want to there's three things. Are the clients' eating habits compatible with their body and with the healing process? Number one. Number two, what's their food quality like? Are they eating organic or not? Yes or no? Is it good, bad, or okay? You just want to know. And are there three, this is important, food allergies, intolerances, or reactivities? And is there any, how can we just know these three things? So I want to talk about the dietary intolerance component, because I have a feeling that most of you out there are already really equipped at finding out food. You've got your own food dietary thing that you do. So I'm not really that fond of food sensitivity testing. There's occasions where it's been useful, but overall, I'm more concerned with sort of these categories, because to me, these categories have you can debate it, you can disagree with me, it's fine. But these categories have shown to me to be really significant when they show up. And addressing them, as we'll show in a case study, has been significant. So oxalates, this was a big deal. And when I was working with a client recently who had quote unquote sulfur sensitivity, it wasn't sulfur that was the problem, it was the oxalates from her food intake that was the problem. And when she started to reduce oxalates, her heart rate variability noticeably increased during that whole period and has maintained that level consistently since. And her sulfur sensitivity got less. She's now able to tolerate sulfur-containing foods more. So there's a number of genetic associations. Again, this will be in the new report that can impair oxalate metabolism. So think about these things. So just, take an inventory. Do these foods create any kinds of issues? One of the things just to be aware of are the pain syndromes that you're seeing and reaction to sulfur-containing foods. If you see that, think about oxalates as being causative. We can start by obviously slowly reducing the oxalate. You can't pull off too quickly because it could cause an oxalate dumping reaction. But we can use things like the pyruvate salts. Microbiome Labs has a nice product out, vitamin K2 and pyruvate. There's evidence that it's working. Megaspore could be good, but it can cause die-off or dumping symptoms, oxalate dumping symptoms in some people, because it probably increases oxalobacter formigenes, which degrades oxalates in the intestines. B6, citrates, and bile acids all have shown to be useful for controlling oxalates. Salicylates, this is tough. And salicylates, here's the symptom list. Cystitis, tinnitus, swelling in hands, itching. They can cross-react with histamine symptoms. But if you do the aspirin provocation, take a single aspirin. If it causes a problem, within minutes, within a couple hours, suspect that you've got a salicylate problem. But there's two kinds of salicylate reactions. The immediate ones, which are more immunological, or the delayed reaction, which is more gastrointestinal or hepatic. And remember that glycination in the liver plays a role in degrading salicylates. So glycination is phase 2 in the liver. Low-dose immunotherapy, here's the study on that. This was an in vitro study that they looked at reducing salicylate sensitivity in cells, as well as, so low-dose immunotherapy is a type of homeopathy that was done by Ty Vincent, I believe is the guy. He's a doctor, he's an MD, and I saw him present recently at TFIM. It was excellent, and I recommend looking into LDI for some of these severe hypersensitivities to certain things. I think it could be really useful. So that's that study. You can look at that. FODMAPs are next. For SIBO, look at markers 14 and 15 on the O test. If 14 and 15 are high, suspect SIBO is primary. Even if it's above the midline, I'm going to say it again. If markers 14 and 15 on the OAT are above the midline together, suspicious for SIBO. I found that to be more consistent with the symptoms than the actual SIBO test. And you don't need to run the stupid SIBO test. I mean, I shouldn't say it's stupid, but a lot of times it's inconclusive, and I don't know if it's really going to give you the data that's going to change everything, because treating SIBO is so hard anyway. But I think it's just because we're not looking at the right things. We're not looking at the vagus. So, but here are some of the symptoms, and nonetheless, FODMAPs can be an issue. But guess what? This is something I found, is that the raffinose that's in some of the FODMAPs, more than the FODMAP itself, can be broken down by alpha-galactosidase, which is a digestive enzyme. So if that improves things, you can use this enzyme to counteract some of the SIBO symptoms. Obviously, we know about gluten, gliadin, and dairy, so I'm just going to kind of brush through that. Sulfur and nightshades, I just put that on there because it's important too to see if this is affecting your client. But again, with the sulfur issue, we used to think that it was the CBS gene. I don't think that that's what it is. I think it's an oxalate problem. And I've had enough cases to show that the oxalates were causing sulfate issues. Okay, so again, if you got questions, everybody throw them on the chat, because I'm going to start to field these in a minute. And then the histamines, we know about these too. All right, so that's that, and thank you for that 83-slide presentation. So I'm going to stop the screen share because I want to just go over. I want to go over my client protocol. So in action. So I'm going to turn the screen share back on. So let's do that again. Okay, so we're getting closer here. Sample client protocol, there it is. Okay, so I'm going to hit these questions in a minute, I promise. So everybody start popping questions out there, and I'm going to just rattle through them one by one. So this is how I work. So in my clinical practice, this is what I'm doing. I'm creating these documents, and this is quite extensive. This is what the client gets after each consult with me: a 9-page PDF with a table of contents that they can navigate with. So what I'm doing is I'm creating a symptom tracking profile. This is extremely valuable. It's very important. This is a client, age 38, and she had all kinds of health issues initially. I've done several consults with her since. She's gotten way better since then, but you can see some initial improvements. But what I wanted to highlight here is the 7 mechanisms. So I'm actually writing these up in the initial report to the client. So I pull out all the data that I've assembled, the story she's given me, the intake I've taken during the initial consult, and the intake form I sent her. And here's all the environmental components that I found. Here are all the pathogenic components that I found that also correlate with the intake. Here are the structural issues that I found. So she had a gallbladder surgery. Here's some of the medical iatrogenic stuff. These are her own words. So the benzos, right? So I'm wanting to just go through all of this and just send it to the client, have this for my own reference. And with the genetic stuff, what I did here with her was I just pulled out, after I looked at all of the markers, after I looked at everything, I said, okay, here's all the genetic variants I think could be affecting you based upon your symptom presentation and everything that's going on, right? I said, this is what's probably, stuff that needs to be sorted out at some point. This is how I use the genetic data. I don't just pick and choose things. I'm looking at finding how they all fit together. So, but this is how I work. This is my, lab test analysis. This is the summary review that I do for all of it. And I create protocols here. And then all of this is the symptoms from the survey. I just copy and pasted this on the report. So this is the lots of Bartonella symptoms, and she certainly tested positives. That was identifying that, and the oxalate thing was a huge, huge piece of things that were uncovered that led to significant improvements over time. So I just wanted to show you guys that, because this is how I do it, and this is how to implement these 7 mechanisms in your initial client call consult. Let's get to some questions. Okay, any questions? So I know it's been 2 hours. We're going to go a few minutes over. So Tina, for the client written history, what do you ask them to write so that they can include all the information we're trying to pull out from them? So here's what I say.
Write your story and send it to me. And guess what? 9 out of 10 times, the client loves writing. They love talking about everything that's wrong with them. So I give them the liberty to do that. Give them the liberty to do that. Tell me everything that's wrong with you. And then I just go through it. Next question. What is the issue with exposure to cold under trauma and vagus nerve? Sorry, that was meant to say that cold exposure can improve the function of the vagus nerve. Next question. Where do you find biodynamic craniosacral touch therapists? If you go to there's some, but the biodynamic craniosacral therapy websites list their practitioners, and some of them do this more subtle touch, particularly the schools of Hugh Milne, M-I-L-N-E, and Georgia Milne, M-I-L-N-E, and anyone that's been trained by Charles Ridley, R-I-D-L-E-Y. Those are the three top, in my opinion. And if you find practitioners that do that work, this stuff can be so powerful. I have a practitioner that I see regularly for myself, and some of the deepest healing I've experienced as a human being on this planet, and I should also say some of the most mysterious. I'm watching my body do these things. I'm not even involved, and what my body is doing is just like it's taking over. There's a force that's going on that's beyond my awareness, and it's happening. But if you can find somebody to really pull that, it's great. Could you please explain further the interplay of oxalates and sulfur intolerance and CBS? So I know that sulfates and oxalates can compete in the cell, and I don't quite know all the different mechanisms of interaction, but I can tell you that they interact. And if you go down the oxalate metabolism rabbit hole, you'll find glyoxylate pathway, you'll find glycine in the mix, you'll find how Bartonella and Lyme can disrupt calcium metabolism. And I think that that's probably a central issue that's going on, is these stealth pathogens in the connective tissue causing calcification and causing a disruption in how oxalate are expressed. But there's also genetic predisposition to oxalate metabolism, like the SPP1 osteopontin gene, for example, is strongly involved. And I have variants that are going to be the new nutrigenomics report that show that. For how long do you use binders? I like to rotate. I don't like to stay on it indefinitely, but maybe like 7 to 14 days on and off for a few days. It just depends. Some people do take it long term because they need to. Some binders are, like the Toxa Prevent from Europe is the patented form of zeolite that's really good. Some of the other zeolites are really good too, like stuff from BioPure, Zeobind, and Lava Vitae from Germany. Those are really good zeolites. Those are probably good to take long term. I mean, there's different binders. So I mean, chlorella can be taken all the time. So I mean, it depends on what you're trying to bind. Trying to bind mycotoxins, hopefully, a few months is all you'll need. But sometimes you need to go longer. Next question. What is the push-catch protocol from Quicksilver? Quicksilver Scientific has a push-catch product, and it's basically liposomal herbs in their liposomal carrier, which stimulates the gallbladder and the bile ducts to secrete bile, and then that's the push, and the catch is the binder, which is the Ultra Bind, I think is what it's called. So you can modify that just by using their bitters number 9. Which is like a bitter that stimulates bile. It's, again, phospholipid carrier. And also you can use another binder like the GI Detox. Some people like that and respond better to that. So that's push catch. So it's basically stimulate gallbladder, catch it in the intestines, bind it. How do you do an aspirin provocation? It's as simple as that. You just take a single aspirin and monitor if there's a reaction, an adverse reaction that looks like a salicylate sensitivity within 2 hours. When you combine liquid bentonite with GI Detox, what is the dose you recommend, and is this also taken on an empty stomach? The dose should always be the minimal dose that does not provoke an adverse reaction. Taking a little bit So if a half a capsule of GI detox and a quarter to a half a teaspoon of liquid bentonite is good enough to mitigate some symptom and not produce an adverse reaction, that's your dose. Stay with that. Using more of something is not necessarily better. So the dose really depends on each person, to be short answer. How do you improve ferritin if it is very low, and what are the optimum levels on a blood test? 15 for females, like 15 to 200, and close to if you're a male. It can go on the lower end if you're female, but if ferritin is low, you got to figure out why it's low. If it's low, you got to look. The first thing I'm going to be looking at is infection and toxicity or inflammation. Ferritin isn't the only biomarker I'm looking at. You can monitor the effects of iron by looking at the MCV. If the MCV, mean corpuscular volume, is between 85 and 93 on a blood test, but the ferritin is low, so what? I don't care about the ferritin, because the iron is obviously, the iron metabolism is okay. The MCV is optimal. If their MCV is really low and their ferritin is really low, then that's an iron problem. And I would look at inflammation, gut inflammation particularly, gut infection possibly, something hijacking an iron transport protein. So you can suss that out by looking at the transferrin or the TIBC, total iron binding capacity. If the TIBC is low, then it suggests a transferrin deficiency. And if there's a transferrin deficiency, it suggests acute inflammation, because transferrin is an acute phase negative reactant. It will be suppressed with acute inflammation. Could the push catch be helpful with Gilbert's? Thank you, good question. We'll talk about Gilbert's next week more in detail, but the short answer is yes, it can, but I've had a Gilbert's client do well initially, but have all kinds of sciatica as a result and problems associated. So sciatica can be caused by a gallbladder issue because of a gallbladder 31 meridian, which is an acupuncture point. And I see that over and over again. When you've got sciatic problems, look at the gallbladder. So short answer is yes, but I would use the calcium deglucarate first, because that can lower the total bilirubin by 30%. Again, it's a glucuronidation problem in Gilbert's. So we'll hit Gilbert's next week. More questions. Let's keep going. So, I like the Viome test. I like it better than the pathogen testing. I think because it gives you a little bit of a better indicator of some of the keystone strains, right? And it's really the keystone strains that we're trying to evaluate. What do you think about the research that has suggested that vitamin C at moderate doses may reduce copper levels? Yeah, I've heard about that, and I saw the study, I read the study on that, and it was actually not conclusive. I have to pull that up. And if you pull up the abstract on that study, it actually showed that after a certain length of time, the copper levels normalized, if I remember. I think I'm saying that correctly. So if it may have had a temporary copper reduction, but over time it didn't. So it may have been a time-dependent thing. I have to look at that again, but that's an interesting question. Have you found any patterns associated with the opposite of hypermobility? Are these hypermobility symptoms associated with stealth infections or potential causes? Yes. Some people can have EDS symptoms and actually have a lack of mobility, paradoxically. And the theory there is that the muscles are compensating for the hypermobile joints. As that person gets older, as estrogen and testosterone levels fall, the muscle composition may decrease as well, revealing the more hypermobile condition. Are these hypermobility symptoms associated with stealth infections or other potential causes? Yes, as mentioned, stealth infections like Lyme and Bartonella and mold even can cause hypermobility. And that's why you've got to figure out if the hypermobility that formed is a result of chronic illness or if it came later. If it was genetic or if it came later. You got to suss those two out. What do I think of the Brighton criteria for evaluating EDS? It seems to be more comprehensive than the Baton scale alone. I don't know anything about it. Thank you for bringing up Brighton criteria. I really don't. I may have heard of it, but I never looked at it. Either way, I'm just trying to, because there are joints that aren't being established on the Baton scale, like shoulders and thumbs, for example. So I'm just trying to evaluate basically. I'm going to ask more questions in the initial consult. If I suspect a Baton scale of even 4, it's going to come up for me. Could acrobatics and gymnastics at a young age cause joint hypermobility? I don't know. Good question. It probably can. Not sure, but some people may have a predisposition to it. A lot of acrobats are already hypermobile, but there's a way to be. Hyperflexibility is not necessarily the same as hypermobility. I can do the splits. I used to be able to put my foot in my armpit because I've been practicing yoga for 18 years, but I'm not hypermobile, and I don't have anybody in the family that is either. So you can train yourself to have hyper flexibility, but not hypermobility. So there's a difference. Okay. Do we have any more questions here? Any more comments on whether ascorbate increases oxalates? I know that camu and whole food vitamin C probably is not going to increase oxalates that much. I'm not totally convinced that sodium ascorbate causes oxalate problems. I know that there's some debate even in the literature on that, and I still am okay recommending sodium ascorbate at 1,000 milligrams daily with somebody that has oxalate problems. And it doesn't seem to be causing any issues. So that's my take. I like sodium ascorbate over other forms just because the ion receptors for vitamin C are sodium-based primarily. Any other questions? We're 2 hours and 13 minutes into it here. And so I just want to kind of, we're going to wrap it up here in a minute, but I want to thank everybody for participating in week 1. I'm really excited. We got off to a good start. I gave you a ton of information. I will answer that one question on the push catch in a moment. But I want you to really, really think about these 7 mechanisms and really feel free to integrate that PDF. I'm going to send it out via email again, just to make sure everybody gets it. Implement that PDF into your practice. Feel free to integrate it. So I found it to be absolutely critical to use with every client now. And from a clinical standpoint, we've got to be looking at these things. We've got to really get good at how can we help our clients help themselves better. And we will be sending out all the PDFs and everything will be sent out by email. Make sure that you register for every webinar, because even though you bought the course, you need to be registered for the course as well. And so that email has to come out. So just remember that. The question was about, is it okay to do a coffee enema if somebody has EDS? Sure. There are people that are hypersensitive to caffeine. I had somebody the other day that the coffee enema kept her awake for 3 days. I said, well, still consider doing a decaf coffee enema. I mean, tic-tac-toe, right? We're trying to just move the chess pieces along on the board. Thanks for that data. Can you send me that, Norm, if you can send me the link on that study or the research on the 100 milligrams a day in the adults with the oxalate issue and the ascorbate? I'd appreciate that. Thank you for pointing it out. Yeah, I mean, if you suspect there to be a problem with it, then don't use it. I'm comfortable using vitamin C, sodium ascorbate, but so if there's problems, then go. Camu will not push oxalates. There's enough clinical evidence to suggest that. But if you could send me the research, it'd be great. Push catch. So that protocol that I've been using, so it's the push catch. It's the push catch protocol. You take that and then you do the Byron White and the formulas. Now I have to be cautious. You need experience if you're going to use these herbs. You need to know how to use them. This is not just like taking something you buy at the grocery store. These products are extremely powerful, and people with Lyme or these other bugs will herx on a single drop. And this is stuff you got to really be cautious with. So I have to make that disclaimer that I'm not exercising the use of these herbs unless you are fully equipped to know how to work with them. So I have to put that out there. So the coffee enema is done after doing the push catch and the Byron White. And that's the sequence it's just the sequence that I've seen, that I've witnessed to be effective at mitigating the herxing. But the breathing exercises thrown into that mix, especially the hyperventilating for just a couple minutes, can increase the levels of norepinephrine and inhibit the amounts of TNF-alpha and inflammatory cytokines. That's been proven in that 2014 Wim Hof study. Okay, I'm gonna wrap it up, folks. So thanks so much, everybody, for joining today. I look forward to week 2. Look for the email. Make sure it doesn't go to your spam folder. I'm going to send out another email from institute@metabolichealing.com, and it's going to have all the PDFs, including the slides and all that stuff. So see you next week. Thank you, everybody, for being here today. It was wonderful working with you. If you have any questions, please email them to institute@metabolichealing.com, and I'll try to field them, pending only short answers, of course. And we'll cover more stuff next week, next Tuesday. And remember that you get the recording as well. That'll be sent out automatically by Webinar Jam, I believe, after this call, or it's coming from somewhere. I don't remember where it's coming from. So you've got the replay as well. Thanks, everybody, for tuning in today. Have a great rest of your day. Take care.